about Acute Respiratory Distress Syndrome or ARDS. Especially now with Corona being a pandemic, a lot of patients do go into ARDS. So it is an important topic for the times. So what happens in ARDS? Cardiogenic pulmonary edema. There will be consolidation heterogeneously in the lungs. There will be increased work of breathing from decreased compliance and severe hypoxemia. So let's try to define ARDS. The definition that is used to define ARDS is Berlin definition. There are 4 components to it. Let's enumerate them one by one. First is the timing. The onset must be within a week from the suspected clinical injury or insult, or there may be new onset symptoms or worsening of previous symptoms within a week. Secondly is the imaging. Either the chest x-ray or CT scan must show pulmonary infiltrates bilaterally. And there is a caveat here. The infiltrates should not be because of lobar collapse or consolidation or atelectasis. So these all should be ruled out as causes of the infiltrates. The third component is the PF ratio. What is PF ratio? It is the ratio of PaO2 divided by FiO2. So this should be less than 300 to signify hypoxemia. Again, of course, based on this definition, you can elaborate the ARDS as mild, moderate, and severe. Mild is a PF ratio between 200 to 300. Moderate is a PF ratio between 100 to 200, and less than 100 PF ratio is severe hypoxemia, severe ARDS. The fourth important point is to exclude cardiogenic pulmonary edema or fluid overload status. For this, typically you would require certain investigations, be it echocardiography or transthoracic or transesophageal Doppler, etc. Okay, next let's have a look at the causes. So causes, there are direct causes and indirect causes of lung injury or ARDS. Direct means involving the lungs, obviously. So pneumonia is common, aspiration, blunt thoracic trauma, near drowning, certain drugs like amiodarone toxicity. So these are direct causes. Then the indirect causes, the most common of which is sepsis, severe traumatic shock, transfusion related acute lung injury, when transfusion of more than 15 units of blood products is given, that can cause ARDS. When coming off bypass, pancreatitis. Okay, so these are the indirect causes. Okay, let's talk about pathogenesis. Basically, there is either a pulmonary insult or a systemic insult that leads to inflammatory response in the lungs, which is where the ARDS manifests. So what happens when it manifests? It leads to cardiogenic pulmonary edema, thus leading to the sequel. Clinically, you can divide ARDS into 3 phases. The first is the exudative phase, which manifests within the first 3 to 7 days. So how is it characterized? There is extravasation of water in the lungs, proteins, certain cellular infiltrates, neutrophils, inflammatory infiltrates, etc., leading to accumulation of alveolar and interstitial debris, formation of hyaline membrane, etc., death of type 1 pneumocytes, and alveolar hemorrhage. So this is exudative phase. What happens because of this? That is, the physiological consequences of this are there will be decreased alveolar ventilation because of this, increased intrapulmonary shunting, decreased compliance of the lung, leading to increased work of breathing. This is the exudative phase. Then comes the proliferative phase. From 7 days onwards, maybe for the next 2 to 3 weeks. This is the proliferative phase, which is characterized by resolution of these accumulations, proliferation of type 2 pneumocytes, and clearance of the debris. This leads to the patient symptoms being reduced and the patient coming off the ventilator. In certain patients who are unfortunate, there is a third fibrotic phase which can progress after the second week, wherein there is progressive fibrosis of the lung tissue leading to permanent sequelae. But this incidence has reduced with something called lung protective ventilation strategies, which we will be coming to subsequently. Obviously, there are other causes of pulmonary edema as well. Okay, here are some of the causes. An easy way to remember it would be two conditions related to the heart and blood. So what is related to the heart is cardiogenic pulmonary edema. Related to the blood, acute alveolar hemorrhage. 3 pneumonia, acute interstitial pneumonia, acute eosinophilic pneumonia, and cryptogenic organizing pneumonia. APAP is another condition, which is acute pulmonary alveolar proteinosis, APAP, and 2 dotted conditions. What do I mean by dotted conditions? This is as you see in the X-ray. So, where do you find these dots? Miliary tuberculosis and disseminated carcinoma. Obviously, patients in ARDS will be on ventilators. Earlier it was proposed to use a high volume of ventilation of up to 12 ml per kg of predicted body weight. But now they have come to the realization that patients with ARDS have what can be described as a baby lung. Therefore, to protect this baby lung situation, so we practice something called lung protective strategies. So what are the aims of the lung protective strategies? Tidal volumes of 6 ml per kg. PEEP, a minimum PEEP of 5 centimeters of water. And an aim to keep the FiO2 less than 0.6. Because it may be difficult, you can allow some hypercapnia called permissive hypercapnia, but you have to maintain the pH more than 7.25. That will be the aim. Okay, there were various studies that tried to look at whether a lower PEEP or a higher PEEP, lower FiO2 or a higher FiO2 is good, and the results are still up for debate. Here is an easy chart of PEEP FiO2 relationships to be kept for ventilation. So an easy way to remember this is whatever is the FiO2 requirement, we can keep 20 times that as the PEEP. For example, if the FiO2 requirement is only 0.4, so PEEP should be 20 times that. That will be 8 centimeters of PEEP. If the FiO2 is 0.6, PEEP of 12. So this is an easy way to remember the FiO2 PEEP relationship. That is one of the prescribed PEEPs. But the idea is to keep the minimum amount of PEEP required to try to maintain the FiO2 less than 0.6. Ventilatory strategy. Earlier, they used to recommend a high tidal volume of 12 ml per kg body weight for ventilation. But now they've realized that that leads to lung injury because of something called baby lung. Now let's have a look at this baby lung concept. Suppose these are normal alveoli. And this is how they expand during inspiration. In the case of ARDS, this is how the alveoli look. That is, these are all, the three on the left are all involved in the damage process, whereas only one alveoli is left compliant. Therefore, this is how they expand, meaning that only so much of the alveoli are available for ventilation. Therefore, there is this concept of lung protective strategies for ventilation. So what are these, or what does it encompass? Lower tidal volumes of 6 ml per kg of predicted body weight, giving of PEEP of minimum of 5 centimeters of water, plateau pressures of less than 30 centimeters of water, respiratory rate of less than 35. There is provision for permissive hypercapnia, that is, you can allow the pH to fall up to 7.25, that is, try to maintain the pH above 7.25. Maintenance or aim to get the FiO2 below 0.6 if possible. So these are all lung protective strategies. Okay, we talk about this concept of predictive body weight. This is not the actual weight of the patient, but the predictive body weight. There's a formula for it. So for males, it is 50 plus 2.3 times the height in inches minus 60. Whereas for females, it is 45.5 plus 2.3 times the height minus 60. This is how you come to the tidal volume. Here is a flow chart from Washington Manual. As you can see, if the patient presents with features suggestive of acute hypoxic respiratory failure, the appropriate clinical setting with X-ray proof and PF ratio less than 300, first thing is rule out left heart failure here. So these are the signs that help you identify cardiogenic pulmonary edema. If not, then with the calculation of the predicted body weight in this manner, you'll have to start the mechanical ventilation in assist control mode with the following initial parameters as stated earlier: tidal volumes of 6 ml per kg, PEEP of maybe 5 to 10 centimeters of water, and respiratory rate less than 35. And you'll be aiming at these goals with oxygenation in the range of 55 to 80 or saturation above 88%, plateau pressure of less than 30 centimeters of water, fraction of inspired oxygen less than 0.6, and pH of 7.3 to 7.35. And if these goals are met, because every time it might not be met, if it is met, then it's a good thing. If it is not met, then you'll have to do something else. What would that be? If the plateau pressure is more than 30 centimeters of water, it is harmful So you have to decrease the tidal volume by 1 ml per kg to as low as 4 ml per kg to achieve plateau pressure of less than 30. If the plateau pressure is less than 25 centimeters of water and the tidal volume is less than 6 ml per kg predicted body weight, then you can increase the tidal volume by 1 ml per kg until the plateau pressure is more than 25 centimeters of water, if the other parameters are not met within this. Increase PEEP using minimal amount necessary to maintain FiO2 of less than 0.6. Suppose, now looking at the pH, if the pH is in the range of 7.15 to 7.3, you can increase the respiratory rate and bring up the pH to 7.3 and above, or you can bring down the PCO2 to 25. If the respiratory rate has been maxed out at 35 and the PaCO2 is less than 25 and still there is acidosis, you can consider sodium bicarbonate. Suppose the pH is less than 7.15, increase the respiratory rate to 35. If the pH remains less than 7.15, then sodium bicarbonate can be used, and you can increase the tidal volume by 1 ml per kg until the pH is more than 7.15. In this case, there is an exception given that you can increase the plateau pressure to more than 30. Now the PEEP, although it has been said here that minimum amount of PEEP necessary to maintain FiO2 less than 0.6, some prefer to use a higher PEEP of 10 to 15 centimeters of water during the initial 2 or 3 days. There is this concept called open lung strategy. This is a combination of what we describe as lung protective strategy along with PEEP optimization and possibly recruitment maneuvers. What is the aim of open lung strategy? This is to keep the aeration going in functional lung tissue and prevent repeated collapsing and opening up of the alveoli, leading to atelic trauma, and also the stress that is experienced by the compliant normal tissue. That is the aim of the open lung strategy. The ventilatory strategies, they might not be enough. That's when you require rescue therapies. PaO2 of less than 55 millimeters of mercury, or SaO2 less than 88% with FiO2 of 0.7 or higher, or plateau pressures of more than 30 centimeters of water. This is when you'll require rescue therapy. What all comes under rescue therapy? Giving of certain inhalational agents, be it prostaglandins or nitric oxide. This is one of it. Secondly, prone ventilation. Prone ventilation is supposed to correct ventilation perfusion mismatches and improve oxygenation, as well as distribute the gases in a better manner, thereby protecting the lungs as well. So this is done by an experienced critical care specialist with proning for 18 to 20 hours in a 24-hour cycle. Of course, everybody cannot be prone. There are contraindications to proning, be it injuries in the ventral part like burns, or hemodynamic instability, unstable fractures, spine injuries. So these are all contraindications. There are certain salvage ventilatory strategies when the traditional ventilation strategies don't work. These include inverse ratio ventilation, wherein the inspiratory time is more than the expiratory time. There is high frequency oscillatory ventilation, which is now not recommended anymore. There is airway pressure release ventilation. Others include use of neuromuscular blockade and ECMO. Other rescue therapy includes the use of steroids. Steroids can be used if it is within the first 7 days, preferably within 72 hours. A moderate dose of a steroid, for example, methylprednisolone 1 mg per kg, bolus followed by 1 mg per kg per day infusion. This can be run. If any benefit is to be there, it will be seen within 3 to 5 days. If not, it is to be discontinued. If you do find the benefit, continue it for 14 days. Then you can taper it to 0.5 milligrams per kg per day infusion for a week, and then maybe another week later 0.25 milligrams per kg per day, and then stop. If it is from 7 days to 14 days, the benefit is said to be less, but you can try it. Again, you might find benefit within 3 to 5 days of using it in the form of decreased ventilatory requirements or decreased infiltrates on chest x-ray. If not, you'll have to stop it. More than 14 days of patient in ARDS, steroids are not recommended. Another important aspect of ARDS is fluid management. Our aim here is to maintain perfusion to the organs while at the same time attempting to decrease the pulmonary capillary pressures, because higher pressures lead to worsening of pulmonary edema. So there's a balance. In conclusion, ARDS is a severe life-threatening pulmonary edema with its characteristic clinical, radiological and physiological consequences. In order to manage it, we use volume and pressure limited ventilation, conservative fluid management, and early moderate steroid use. If failed, then rescue therapy. Alright guys, have a nice day.